All right, guys, we're back. Part 2 of the head, neck, and spine trauma. Let's talk about the pathophysiology. We kind of touched on it when we were doing A&P a little bit, that quick review that we just did. But again, when I'm looking at a patient such as this, again, you pretty much, you got blood coming from the nares, the mouth, ecchymosis, again, around the eyes. But these are soft tissue injuries, but it also could be indicative of brain injury and brain swelling. Blood's going to come out places pretty much anywhere that it can. Usually the neck is actually anatomically well protected because we can tuck in bring our shoulders up and usually protect ourselves that way. But again, usually the problem is when we fall straight down on our head, we get axial loading, or we land on our feet from a height, and then it kind of compresses everything. So kind of keep those in mind with the mechanism of injury. Now, the penetrating injury, unfortunately, they stabbings or gunshot wounds, and they usually end up tearing something along the head or spinal cord. The problem is that the good news is that the knife wounds usually don't get into the cranial vault unless somebody really does a good job there. But the gunshot wounds definitely they definitely break the cranial vault. As a matter of fact, that's one of the biggest problems. The good news is usually when you got a gunshot wound to the head, most of the time that's kind of a permanent thing. Traumatic brain injury, by the way, is capable of producing physical, intellectual, emotional, social, and vocational changes. So keep that in mind when you were dealing with these patients. The direct injury is the actual physical problem, the disruption of the blood flow, the central nervous tissue. Again, serious jarring can also do this, or coup or contra coup injuries. That's the actual striking of the object, and then it collides forward. Remember that you get 3 types of injuries there, especially like when you have a acceleration-deceleration injury. They go forward, then the skull hits, and then the brain hits behind it, and then when it actually ricochets back, that would be the contra coup part of it. It sloshes back. So this is an example of, again, the contra coup effect that happens with this. But it can cause damage on both sides of the brain. Now, again, you can get cerebral contusions, intracranial hemorrhage, epidural, subdural, or intercerebral hemorrhage. All of these things are possible with a direct brain injury, okay? And they're called, by the way, focal injuries, okay? Your intracranial hemorrhages, again, is your epidural hematomas, your subdural hematomas. The epidural is between the dura mater and the skull's exterior surface. And the way that I kind of remember that an epidural hematoma, if I'm looking at it on x-ray, it looks like Stewie's head from Family Guy. And they're like, oh, wow. And when you see them, then you immediately know. Subdural hematomas on x-ray, they kind of look like a crescent moon shape. You'll see the dark and the changing in there. Very slow blood loss. And again, usually epidurals is usually pretty quick. And the problem with an epidural hematoma, by the way, is they'll have what's called the lucent period. So they'll get knocked out. They'll wake back up. They're 30, 45 minutes. They feel great. And 45 minutes later, they're dead. And the reason is because, again, there's bleeding going on into the brain. It's adjusted, then it stops. Where your subdural hematoma, a very slow leak. Matter of fact, this might be the lady that you get to. She's really confused, not really knowing what's going on. But yeah, she fell yesterday, bumped her head. That's usually the subdural bleeds. And then any type of intercerebral hemorrhage, that's actually from the tissue. The blood loss is minimal, but it causes a lot of damage to the tissue, to the nervous tissue of the brain. A concussion it's a mild anoxical injury. Basically, best way I can say it is a brain bruise. Is probably the best way to say it. Again, so it's usually mild. They can have mild, moderate, severe, and a diffuse anoxial injury is when you get severe acceleration deceleration mechanisms. This is what the football players, the NFL, the college football. That's why they've really put in a lot of protective measures, because they were getting players with a lot of diffuse anoxial injuries. Not only that, but continue of these. Okay, it talked about concussions, diffuse injuries. There we go. Indirect injuries. Now, this is when the brain tissue actually starts to swell. It actually begins to swell. and then it exacerbates the hypoxia, okay? So again, and it's a progressive state, by the way. It usually, the more it swells, of course, the worse the patient's going to get. And this is where we usually come in. We usually have the first injury, but then the swelling starts in the middle of us trying to either extricate or get these people out, which, again, complicates the EMS worker life, definitely. The cranial volume, just remember, it's fixed. It can't swell any more than what the room is up here. The only thing it can do is stop flowing blood up there. Bad idea. Or part 2 is get the cerebral spinal fluid out. And that's only a limited amount, okay? So a very limited amount. By the way, hypocarbia, it can contribute. So it can contribute arterial constriction, which is why we keep telling you guys don't overbag somebody, because it actually decreases blood flow to the brain. Now, here's the deal. If there is a time that you might maybe want to do this, is when you do have a high index of suspicion for intracranial pressure. At that point, you do want to hyperventilate your patient. You want to have your end tidal, instead of between 35 and 45, you might want it down around 30, okay? And again, making sure you've got plenty of oxygen. By the way, this is a very stopgap temporary measure to try to reduce intracranial pressure. And unfortunately, by doing that, the idea is you reduce the central perfusion pressure just a little bit until you can get to the hospital and more definitive things can happen. But remember, when you do that, by the way, you're also kind of robbing Peter. If you're closing down blood vessels in the area, again, that's another problem. You're not delivering oxygen correctly. The good news is hopefully you've hyperoxygenated, the patient has a 100% oxygen level, so therefore oxygen is still getting up to the brain. Signs and symptoms of brain injury, usually altered mental status, alterations in personality. They can have amnesias, whether it's retrograde or anterior grade. In other words, they don't remember things before the incident or after the incident. Now, Cushing's triad, this one we should all remember from EMT school. Again, increasing of the blood pressure, slowing of the pulse rate, irregular respirations. It is a sign of increased intracranial pressure. Now, again, by the way, vomiting, really bad sign, by the way. Body temperature changes, a really, really bad sign. The changes in pupil reactivity, and again, decorticate or decerebrate posturing, okay? Decorticate bad, decerebrate really bad, okay? Decorticate bad, decerebrate really bad. That's why we got it on our Glasgow Coma score. By the way, make sure you know your Glasgow Coma score. If you don't know your Glasgow Coma score, you need to make sure that you've got it back down. The quiz I did the other day, we had some folks that didn't know the difference between flexion and extension, so make sure that you know that. Make sure you know about localizing pain versus withdrawing from pain. All of these things you need to make sure that you remember, okay? Back to this, central syndrome. So what they're talking about here is when the brainstem actually gets compressed and starts to squeeze. That's when they go into they have what's called the Cushing's reflex as part of that Cushing's triad. But what it also does is it increases vagal nerve stimulation, which is why the heart rate goes down, but also the chain-stoke respiration. So they're going to start having a cyclic breathing, okay? That's why it happens, is because it's actually squishing the brainstem. By the way, when the midbrain gets squished, again, that's when your pulse pressure widens, your heart rate goes bradycardic, the pupils will become sluggish and non-reactive. Yes, the pupils are the windows to the brain for us, and we really need to take a good look at the pupillary responses, especially when we have an altered mental status. It might be the difference between knowing whether or not this patient is actually having a brain injury or an anoxical injury versus they're something that's affecting them, something else that might be affecting them. Pediatric head trauma. Again, the skull, remember, does not form completely at birth. It's usually about a year to 2 years before it completely, the sutures actually fissure, and they actually have it. So they're going to have soft spots on their head, so we got to protect our little ones for that. If you see fontanelles there, again, if there's increased intracranial pressure, you're going to see the fontanelles bulge, okay? And again, remember that a kid has a proportionally larger head, and they accommodate increased fluids, but they have a small total body volume. So remember, they don't have the reserves like an adult does. And again, intracranial hemorrhage may contribute to hypovolemia for the little kids, okay? Spinal injuries, again, usually they lose they can lose anything along the way there, but it can cause tingling, other problems there. Your mechanism of injury, again, they can hyperextend it, they can hyperflex it, they can compress it. So all of these things, anything that can stretch or pinch a nerve can cause damage. And by the way, most of the time it's in the cervical or lumbar regions. The thoracic has the ribs that usually protect and help cushion that, along with a lot of musculature around that thorax area. Again, the hyperflexion, it might lead to the wedges moving and changing, and if it dislocates a vertebrae, remember all those nerve roots come out from that vertebrae, and again, if you move that, well, it's going to either sever or disrupt those nerve endings from actually functioning. Don't forget about your lateral bends, by the way. So if, in other words, you're tilting your head left or right, again, depending on, remember, when they get impacted, the neck is going to shoot different directions. But you try to find out where those actually, so you can actually tear ligaments or stretch them from one side to the other. So it is a possible. And then again, axial stressing is when you got compressive forces to the spine. And by the way, they can fracture vertebrae with that. Again, they're common from falls from a height and in helicopter crashes, by the way, because everything comes crashing down again. So that it's kind of a normal thing that does happen. So your mechanism for spinal trauma, usually you got to watch out for you want to look for the pulse motor sensation that they're going to have on there. And the upper cervical spine, by the way, is the one that's most commonly affected, which is why, again, we put so much stress for so many years on securing the cervical spine. The more appropriate term would probably be spinal motor restrictions. You don't want to completely and totally immobilize it, number one, because probably, by the way, somebody I found with a broken neck, they don't want to move their neck. I will be very, very blunt and very honest with you. If they've got a broken neck, they don't want to move their neck. Now, the thing is that they know that they have a broken neck, but if they're having a significant break, they're not going to want to move their neck. They're going to be sitting there going, I don't want to move my neck. I don't want to move my neck. So don't forget about, you can have the penetrating injuries, actually knives, ice picks, bullets. Again, they can sever the spine. We've all heard of the case where the bullet's still sitting in the spine because they still have function with the bullet sitting there. So what do? They leave the bullet there. Kind of horrible for getting them into an MRI machine, but so be it. By the way, electrocutions, by the way, can cause a spinal injury. Remember, the tetany from the electrocution can actually cause the muscles to actually break the vertebrae when they're in there. So again, anything along the spinal column that disrupts communication, again, that is considered a spinal injury, okay? And it can prevent sensory nerves from communicating with the brain, as well as the motor function of those. Again, by the way, you can concuss or contuse the spinal cord as well. So the concussion is a temporary loss of the cord function, where the contusion is, again, is bruising, okay? And it is likely to repair itself. A lot of the football player injuries we can actually have spinal cord concussions, literally where they weren't moving when we first get to them. Maybe by 20 to 30 minutes in, they're able to move their hands. So again, keep that in mind when you're dealing with these patients, that you don't know whether it's a break or an actual. We're going to assume it's a break until proven otherwise, but it could be just a contusion or a concussion to the cord. Yes, you can actually lacerate the cord. Again, some recovery is expected from a laceration, but if it's a significant one, you're probably going to have you're going to have deficit on a permanent basis. If it disrupts the blood flow, you can irritate the blood-brain barrier. Again, if it transects the cord, that means the complete cord is totally cut. All right. So again, If that happens, usually if it's at the thoracic spine, they're gonna probably have paraplegia, and then they're not going to be able to control their bladder at that point. If it's if it's the cervical spine, you're talking about quadriplegia, and pretty much everything from the neck down. They're not going to be able to feel it. They're not going to be able to move it. So again, signs and symptoms: paralysis, pain, tenderness, impaired breathing. Remember, all the control systems run through the cervical spine. Impaired breathing, the spinal deformity, priapism, that's an involuntary erection of the penis, posturing, loss of bowel movement or bladder control, and again, they won't be able to feel anything in wherever the break is and lower. Okay. The other little complication is that if you lose your control function, it also controls the blood vessels, and because of that, all the blood vessels relax. Well, it kind of creates a disruptive shock, what's called neurogenic shock, but it's kind of like a hypovolemia, only because we made the pipes bigger. Okay. And so again, the biggest way to treat that, number one, is fill the pipes up with fluid. But number two is again, you might have to end up giving these folks a pressor of some sort. Usually norepinephrine is the one that we usually end up giving for a spinal cord break. Now, again, the acute phases of a spinal cord syndrome is a respiratory insufficiency, quadriplegia, and this is again a complete cord transection, usually up in the neck area is when this happens. The other problem is they can start having muscle flaccidity, they can start having spasms, and they actually develop hyper reflexes, which actually cause a lot of pain for the patient. But again, it's not actually true pain per se. I mean, it feels real to the patient. And when we start dealing with these patients that are chronic problem, as far as they're now at home, we're calling them. These are things that definitely happen. Spasms happen. Their control of their temperature is actually kind of a really big problem for these guys. Brown-Saquard syndrome. This is one of those cool little trivia things. It's a penetrating injury that affects only one side of the cord. Okay, so you can have some sensation through there. Okay, so it's a partial transection. And the cauda equina syndrome is when the nerve roots of the lower spinal end compress, and then it interrupts sensation or motor control. Both of those I think you're going to see later. We talked about spinal shock already. We talked about the neurogenic shock. Autonomic hyperreflex syndrome. Again, it's response to the neurogenic shock, and they begin to, they can actually start to have seizures. They can have strokes or death. And again, it must be treated immediately, okay? Again, we need to stop seizures. Again, do things to prevent the stroke from happening. The other thing is we treat it. Now, related to sports injuries, these are transient syndromes. A stinger is usually when they get a burner or a pinched nerve, or they can get transient quadriplegic. These is a little bit more serious. It's usually due to the bruising or concussion to the spinal cord when that happens. And actually, it is very scary for usually the athlete, usually your younger athlete that has this. But the good news is if it's just a stinger, if it's just a bruise, usually they can recover from those very well. Pediatric spinal injuries, again, between 2 and 10, tremendous changes to the spinal cord happen because of that. It has mobility and elasticity, and the larger size of the head, remember, that's on the bowling ball. Just remember, it's a bigger bowling ball, and they don't have the muscles. By the way, with your infants, that's why you support the head, because they usually don't have the neck musculature support. It's very floppy. It's very, very dangerous. You can flop the head and dislocate things by not supporting the head. So we always make sure that we support our head in this case. And scalp injuries. Again, usually very superficial, minor. They can be kind of deep. I've had people bleed pretty extensively from these. I think where I used to work was the machete whacking capital of the world, and they love to take their machetes upside somebody's head. And again, scalp bleeding was kind of a big thing. Again, this is an example of a scalp wound. Again, the good news is we can suture those up usually. It's going to take a little bit of time to do. Your scalp injury, again, it's a good route for infection, but they do tend to heal quickly. But you can actually get flap avulsions as well there. We kind of want to lay that back and try not to expose the cranium if we can. Linear fractures are small cracks in the cranium. About 80% of all skull fractures are linear skull fractures. The depressed ones, that's where the inward skull actually goes into the patient. So these are the examples of the types of skull fracture. An impaled object, an open skull fracture is when you actually have brain to the scalp area. Linear, again, linears are our big ones here, gang. They're the ones that usually, these guys right here, again, it forms a crack. And again, the problem with the depressed skull fracture is we don't want to push down on that and cause any more problems. All right. We're going to hold up here. Oof, 20 minutes. Wow. Going through it quick. All right. So we'll pick up on the next one. You'll see you guys later.